So I'm delighted we can open our chat box now and encourage you to put your questions in there. I've had a few through already. And if you put your questions in there, we've got Professor Lambert and Monica with us. We've also got Dr. Anne Cruikshank and Dr. Zara Hussain. So any of those doctors and Monica as the herbalist will be happy to take your questions. Here's one here. Could you please advise as to when and whether to do a blood test for Lyme disease if someone wishes it, having been bitten by a tick 2 days previously, but no EM rash? So we covered a little of that last week, but I'm wondering if Dr. Cruikshank would maybe like to take that one for us, please.
Yeah, no, I think there would be, if that was the only tick bite, there would be no reason to carry out a test. And I think the importance here is for GPs to have confidence in explaining why, because it won't help either way. It won't exclude it, and it's not going to confirm it at 2 days post bite, highly likely. So you either need to wait a bit longer, give them clear instructions on what to look out for, make sure you've recorded in the notes that they presented with concerns over a tick bite, so that if they come back at sooner or later, that's all there in the information. So it's confidence in saying, no, you don't need that test at the moment, but we're happy to see you if there's a problem.
Thank you, Anne. That's helpful.
Can I just add something there? So as well as what Anne has mentioned, it's understanding what the test does. So like has been mentioned, it's not a direct test of an infection. It's a test of the body's immune response to the infection. And that can take a while to happen. So there's some interesting work done by Orcott in the States, where they've looked at how long it takes for people to develop an immune response to Borrelia, and it can vary from a couple of weeks to a couple of months. So they certainly won't have a positive test at 2 days because their body won't have generated an immune response. So logically, it's not a helpful test in that setting. So that helps you understand the background of why it isn't appropriate at that time frame.
Just additional comment. When you put somebody on PEP for HIV, you do a HIV test follow-up at 4 to 6 weeks. When somebody's exposed to syphilis, you have to do the repeat syphilis test up to 3 months afterwards. So it's called a window period. It's not unique to Lyme disease. It's true for every infection, including Lyme.
Thank you very much. So issues there about consistency of approach as well, isn't there? Thank you. Here's a different question. There's a vaccination for tick encephalitis. Will there ever be a vaccine against Lyme?
Okay, there were 2 vaccines licensed. I was the Data Safety Monitoring Board when I was at Hopkins, their vaccine group, in 1997. So there was 2 vaccines licensed, one by Connaught. I was on their Data Safety Monitoring Board, and there was a second company, but they were licensed, and then actually they were withdrawn from the market. So there have been, and it's not clear whether it just wasn't popular or whether there was kind of immune kind of side effects and the company was afraid of litigation. It's not really clear, but there are a couple of new Lyme vaccines in biotech companies in development, going through phase 2 and 3 phase testing. But like I said, we've gone through this back in 1995, 96. So there are concerns, I think, that the vaccine could have adverse immunogenetic side effects for people maybe who already had Lyme disease. But there are some being developed right now.
Thank you for that, Dr. Lambert. Here's a slightly different question. Someone's asked that they found bioresonance and Rife helpful. Some of you may not know what that is, so we may have to explain that. Of course, having been treated extensively with antibiotics for late Lyme, they then found bioresonance and Rife helpful. And they're aware of others who've also benefited who've had late stage Lyme. Have Dr. Lambert and Monica have any experience of patients using this and any positive reports to give?
Yeah, well, look, I have lots of patients that I've got no idea what it is, to be perfectly honest. but and we're herbalists and infectious disease doctors here, so I don't think we're really able to say. But patients have said it hasn't helped, it hasn't hurt them, and in some situations it helped them. So I can say nothing more except that people haven't had adverse effects, and some people have shown benefit.
Thank you. Monica?
Yes, I would agree with that. I don't know a huge amount about it, and I haven't, managed to find many papers that have educated me about it. I'd love to know more about how it does work. All I would say is that I am very wary of bioresonance or a biomagnetic pair therapists diagnosing people. Very often people come to me and say, my biomagnetic pair therapist, told me I had, a certain co-infection or whatever. And, sometimes, when they have blood tests done, they're right. I think, if you see a lot of patients, you start to see patterns. But, very often they're wrong, but then the patient is in a real quandary as to what to believe, the blood test or their nice bioresonance practitioner as well. So I tend to get a bit, arsy when I'm presented with diagnostics. But, as a form of treatment, I don't think that it's harmed anybody that I haven't had the experience where it's harmed anybody.
May I make a comment on that?
Kate, would you like to make a comment? I don't know if your sound's working terribly well, but try again. I think your broadband's maybe struggling. Okay. You're mute and we're struggling to hear you.
Can you hear me now?
Yes.
Yes, okay. I just wanted to make a comment because I've had a long career in the NHS as a nurse. And I would have been very, very cynical about some of these treatments until I'm happy. I just probably helped me the most, actually, out of all the things. But I would have certainly never believed that until I became a Lyme patient myself. So I just wanted to raise a...
That's helpful. That's helpful, Kate. So what you're saying is you would have previously been quite cynical about treatment and approaches like that, but having been on the other side of the equation, you've actually found them helpful. So that's useful to hear, isn't it?
Yes.
Sort of lived experience.
But
It is, and I said
many are really... Sorry.
Kate, I think you're struggling tonight, so I'll maybe get you to put any comment in the chat box if that's all right, because I think your broadband's struggling a bit. Thank you. Monica?
I do think it's important to keep an open mind, and, patients do know what works for them and what doesn't. I think it's just a shame that, communities of practitioners can't get together to at least publish series of case studies, or, it doesn't necessarily have to be a sort of full-scale clinical trial, but at least case studies and other things so that other people can understand, and through understanding then trust what they may refer people to.
Okay, thank you for that, Monica. Maybe scope there for groups to get together to talk a bit deeper in this. So here's a few other questions. I think we're at the stage where we're almost at 8:15, but we're very happy to stay on for another 15 minutes. So I hope you'll stay with us. Is there a time when it's too late to treat? Who would like to take that one? Dr. Lambert?
No, I don't think it is. I mean, I think that's the issue. I think, my review of the literature is Lyme can persist, just like syphilis can persist for years and years. They're both spirochetes. They don't just miraculously disappear without treatment. So yes, so I think if you've got somebody who's late diagnosed with Lyme, and you take the accurate history, I've seen people years later respond to antibiotic therapy against Lyme. So I think you should give people the benefit down of a treatment if you have taken the appropriate history and you suspect Lyme disease based on your history and the findings, and whether or not there's actually laboratory data to support it. I think I have seen patients respond to treatment, and I think it's a reasonable thing to do. And I think the additional thing is that you hear this all the time. My Lyme symptoms improved when I took antibiotics for something else. That there's lots of tips and hints in questioning people that I think would support that treating them even further down the line than early diagnosis.
Thank you very much.
I would definitely agree with that. I've had patients who've been ill 20 or 30 years and have yet managed to make significant improvement. I think sometimes having had an infection for so long, some damage has been done, and whether or not people can be restored to, 100% health, particularly as, several decades have gone by and we're all getting older anyway. But certainly people can get a good quality of life back again, even when they've been ill for a very long time.
Thank you. So here's a couple of questions for Dr. Lambert. I'm going to take them both together here. At what point, if at all, would Dr. Lambert use disulfiram anti-abuse, as some of you would maybe know it? And are there any other pipeline drugs for chronic Lyme? Two questions there.
Okay, so my response, I'd never used disulfiram. Disulfiram, I actually reviewed the article for the journal that the data was published in. I was the editor for that journal. And, somebody decided for people who had failed all other therapies to use disulfiram, and they reported 3 cases of it. And in 3 cases, people got symptomatic improvement for 18 months. But subsequent studies have kind of shown in a group of 70 to 80 people, about 40% of people responded, but about 60% of people had toxicities. So I think, that 3 cases of improvement in people doesn't mean that everybody should be jumping on the bandwagon to treat with this, a drug that's, poorly understood and may have significant toxicity. Now, on the other side, disulfiram is similar to Flagyl in terms of the way it looks. So it may have activity against Borrelia. And I told you the Cohen Foundation has put millions, and they've actually are supporting Columbia, Johns Hopkins, Tulane, and actually Stanford to do studies on disulfiram. So I think, yes, it may be a benefit, but it's early days. And I think we're jumping the gun by, putting that top of the line to treat people, or even bottom of the line. So I'm not saying it's not going to work, but I just think that we shouldn't be jumping on the next flavor of the month. So second off, there are some new antibiotics coming along, and some of the publications that are coming out of Johns Hopkins and Yang, they've looked in vitro at the activity of a lot of different herbs, a lot of different antibiotics. So lots of different antibiotics have activity against Lyme. However, there's no funding to do clinical trials, safety and efficacy studies. So I think I would hold off on jumping to too many new agents and stick with what we know works.
Thank you for that. That's helpful. Question here about the case that you raised, Dr. Lambert, where Borrelia was isolated from the joint aspirate. Why would it not be treated, do you think? And the questioner saying it makes no clinical sense not to offer therapy because the individual already received it earlier in the disease process. Would you like to comment on that one?
Not really. I mean, it puzzles me why we are paralyzed in treating Lyme disease beyond the prescribed, guidelines. We don't use that for any other infectious disease. So you'll have to ask the people who chose not to treat the patients, not me. Maybe Anne can make a comment.
I was also going to say it's important to remember that just because a patient has been treated in the past doesn't mean they haven't actually been reinfected. It may well be a chronic infection, but there's also the issue of reinfections if they're in the same tick exposure they had previously. So, you know, which might be weeks, months, even years later, but yeah, I would start again, I would retreat. So,
Thank you, Anne. And there's one here, it's addressed to Dr. Lambert, but I'm actually going to give it to you. If you were bitten by a tick, would you take doxycycline as soon as possible, i.e. just in case?
if you're asking me, then no. There wouldn't be a good argument for that. Otherwise, you may be taking it repeatedly. And I think actually Dr. Lambert's opinion is even more significant as an infectious diseases consultant.
I answered that question last week in the question and answer. I'm just saying very simply, you know, I think some guidelines say go ahead and, you know, give prophylactic, you know, doxycycline or short course doxycycline. If I was in old Lyme, Connecticut, where 70% of the ticks are positive for Borrelia, you know, versus in parts of, you know, of Western Scotland where it's 1% to 5%, I think I'd wait and watch, but I'd be very clearly say to the patient, if you start to develop any symptoms, you know, consistent with Lyme fever, flu, pains, this and that, not just in a few months afterwards, but even longer beyond, I think people can present later. So I still think if the GP is seen someday, if you choose not to put people on treatment early following a tick bite, which I wouldn't in most situations, I think you have to clearly document they did have a tick bite. And if they do develop symptoms, even months and months later, if not years, I'm seeing cases of Lyme reactivating years later, I think you should have a low threshold for treating at that time. But that's not prophylaxis, that's treatment at that stage.
Thank you. That's a really clear, in-depth answer there. And here's one that's talking about hyperbaric oxygen. So Monica, you may have some views, and some of our doctor colleagues too. Hyperbaric oxygen is often used by MS patients. Are you aware of it being used by Lyme disease patients?
Yes, some of my patients do use it, and some of them have reported that they find it very helpful. The difficulty is that it's very expensive, and you know, over half of my patients are already on a low income rate, so affordability of treatment is a big issue for a lot of patients.
I would just say, actually, scattered around the UK, the MS charity has quite a lot of these treatment sites. As far as I'm aware, it's something like £30 for a treatment, which is an hour. The idea is people go in, sit on a plastic chair with a mask on, and they have several people in there at the same time. And I know that some MS patients use it regularly on that basis. So it would be less expensive than the individual chambers, but there are only a few of them scattered around the country. I'm not sure how many.
Thank you for that, Anne. And there's one question here, I'm not quite sure I follow it. Demographical chart that shows prominent infected tick in Scotland. I'm not sure if the question is asking, are there charts that talk about prominent areas, or is it something different? Perhaps we can pick that question up in an email to the Lyme Resource Centre afterwards, and we can perhaps point in the direction of some of that graphical information.